Great. Now I will make you host again.
Yeah, sure.
And sorry, you will have to do that Facebook thing again.
Sir, it's already live on the Facebook right now.
It is?
Yeah.
Okay, so then would you like to start right away?
Yes, sir.
Go ahead, Dhaval.
Yeah. Good evening, everyone. First of all, I would like to thank Dr. Gurjin Khan, sir, and Digital Dental Forum for providing me this wonderful opportunity to share my knowledge on this wonderful platform. So, our today's point of discussion is intraoral scanner. The way digital dentistry is moving fast, intraoral scanner is the very first point where we can get and start entering into the digital dentistry ocean. So basically, starting with the intraoral scanner, there are many companies available in the Indian market for providing economical to the premium range of intraoral scanners. So which scanner to choose with? So basically, it's a kind of major dilemma for the dentist. So which scanner should I buy? What factors should I look for? Does the scanning speed really matter or not? So basically, there are major three factors which should be considered before buying the intraoral scanner. First thing is the budget. Second thing is the scan speed, and third thing is the openness of the scan software. So basically, premium category scanners are way too better than the economic one if we compare the scanner speed as well as the scanning data accuracy. But the economy scanners are also doing good. The second thing is the scanning speed. Practically speaking, at the clinical level, we cannot measure the scanning speed in a particular patient because we are never ever going to scan the particular patient with two different scanners with same patient compliance. So ultimately, scanning speed depends more over the operator's skill as well as the patient compliance. And the third thing is the openness of the scan software, whether you will be able to send the open file to your any of the lab, or the scan software or scanner is a closed system where you cannot send the file across to any other platform or any other laboratory, then you are bound to a particular company or a particular laboratory. So third thing is the main important thing before buying the scanner. So you can do the n number of cases with n number of opportunities and with n number of file exportation. So the main thing about the choosing a scanner is the open source file system, which includes the STL file, PLY file, and the OBJ file. So basically, scanning system is moreover depending upon the, like we see, everybody might have experienced the scanning system. It is just a simple video capturing process. So we move the machine into the patient's mouth. Multiple images are captured within a fraction of seconds. And this is basically a point cloud technology where multiple images are cumulated and a 3D representation of the patient's jaw or soft tissue or implant or hard tissue is presented to us in a STL format. Why the scanners are right now overruling the conventional impressions. So basically, when the patient is on a chair side, for a dentist, the dentist mindset is that his impression, first impression, should be the last impression, because it's always a hustle for dentist to make a repeated impression. That is why the intraoral scanner is replacing the conventional impression way too faster. First thing is the patient compliance. So right now, patients are also over smart that they Google the everything. They visit the multiple clinics before final treatment execution. So patients also demand that their measurement should be taken into a 3D measurement software like or any camera software. So it's always a convincing point for the doctor also to convince the patient, like they can lively show the patient what is there in the patient's mouth, what is happening in their mouth, what data is captured, what treatment is going to be executed on patient's database. The next thing is the quality of the impression, where we have tried multiple rubber-based impressions, alginate impressions, polyether impression. Some are economic, some are way too costly, and almost each and every impression material a particular setting time to be followed, particular mixing time to be followed. So everything affects the quality of the impression. Whereas in the intraoral scanner, it just depends upon the operator skills. If operator is smartly moving his hand in patient's mouth, he can easily capture the data, and it takes hardly 10 to 15 seconds to get a good intraoral scan of a particular patient. Then next is the feasibility and comfort of the patient. Whereas conventional impression materials, we need to do many material mixing and many have the techniques. Whereas in the intraoral scan, we just need a sterilized scanner tip, which is easily movable in the patient's mouth, and we are just to go with the scan data. Reliability, that's the most important thing. In the conventional impression method, we take the impression, we send it to the laboratory, and next day laboratory guys tells us that sir, there is a discrepancy over here in the rubber based impression. Right now we need to repeat the impression. So doctor needs to recall the patient and whole cycle needs to be repeated. Whereas in the intraoral scanner, we can evaluate the scan data in a real time method. We can communicate with the laboratory, they can revert back immediately, and on immediately we can rectify our preparation or the impression or the scan data. We can send it back to the laboratory. So there is a minimal recall of the patient or the minimal wastage of the time or minimal or we can turnaround time is very drastically improved. So like here we can see that rubber based impression looks quite okay from the doctor's point of view, but once the model is prepared, we can see very minute discrepancies are there on the model, which is going to compromise the fitting of the final prosthesis. So ultimately, it may lead to the cement leach out, and there might be chances of secondary caries or the rocking of the bridge in the patient's mouth. So these problems can be overcome with the scan data. Real-time 3D information. So basically, the case is shown over here, you can see that the 3D representation or the we can say the 3D designing of the particular lower anterior teeth was sent to the doctor for the approval. So doctor approved the design, and then we made the final prosthesis. But when the prosthesis was delivered in the patient's mouth, we can see that there is a major discrepancy in the height of the both the teeth. So ultimately, it looked the proper into the onto the model, but into the patient's mouth, it is looking very much drastically bigger in size. So basically, it can be due to the reason of plaster shrinkage, expansion, rubber-based shrinkage, expansion, or alginate impression. If taken, alginate impression might have get dried and then it has been poured later on. So these are the problems which we can overcome. Whereas in the intraoral scan data, right now many companies are providing scan softwares where we can put the patients, we can put the margin line into the scan software itself, and doctor can detect the undercuts. Doctor can clinically check the occlusal clearance same as in the scan software, and accordingly we can communicate with the lab. So the scanning softwares are also very much smart these days, that they can indicate everything before patient is ready to go or the data is processed into the laboratory. So basically, dentistry is coming out of the Stone Age dentistry. So ultimately, we were depending upon the technician of the stone department, then rubber-based impression technique, multiple alginate, multiple die stones, type 3, type 4, and number of die stones. And whereas in the intraoral scanning age, we just need a good scanner and a 3D printer. So we are good to go with the directly final prosthesis making. So intraoral scanners are also technique sensitive. If an operator is not that much skillful, there are certain data loss possibilities in the intraoral scanners. But we don't need to repeat the whole scan. In such condition, we just need to take a particular sectional scan or a particular arc scan or particular bite scan, and whole data can be corrected into the software as well as in the CAD/CAM software. Whereas in the rubber base, if the impression is not okay, we need to repeat the whole step from the zero. So we need to recall the patient, we need to use new rubber-based material, and we take a new impression, then we send it to the lab. Lab guy then immediately improves it or not. Then only we can proceed with the case. So technique sensitivity is there in both the kind of the techniques or materials we can say. But for intraoral scanner, we can immediately correct or improve our sensitivity. Another thing is the storage. So in a lab or in a clinic, we people are used to store n number of models and dumping it into our backyard. But with the intraoral scanner, we can just store our data on cloud storage, which scanners are providing free of cost, or any other cloud format like Google Drive, Dropbox, anywhere. And we can easily recall the data whenever is needed. Same way we can provide patient's file to a particular patient also. They can store the data also. If patient is traveling outside somewhere, patient just needs to send us the file and we can immediately rework on the particular patient's data. So that's a biggest advantage of the intraoral scanner. Treatment planning, or like suppose we are dealing with the case of anterior aesthetic restoration, then we need to take multiple stone models. We need to prepare a model, then we prepare a wax mock-up, then we take the putty index and then we try it into the patient mouth. If patient doesn't like it, we need to take another stone model and we need to redo the procedure. Whereas in the intraoral scanner, we just need a particular single file, then we can send the data to the CAD/CAM laboratory. They can do the multiple treatment planning, as well as that they can provide us a digital mock-up directly and we can try it into patient's mouth. So it saves a lot of time, as well as the treatment planning. We have multiple variation options available. So cost and time is also important factor. Like we already discussed that the time factor is very much reduced by the intraoral scanner. But cost point of view, if a doctor is taking a good quality A silicon impression, then a single arch impression costs something around 800 to 1000 rupees for a doctor. Whereas if doctor is investing in 10 lakh rupees intraoral scanner, then a particular single arch scan is costing something around 40 to 50 rupees over a period of time of a span of 3 years, we can say. So it saves a very much lot time, as well as chairside time is very much drastically reduced for the doctor. When a process is delivered to doctor, minimal chairside adjustments are required. Just snaply, you can fit in the processes, check the occlusion, and patient is ready to go. There are no chances of the undercuts or fitting issues are there. So discussing about the workflow, in a conventional way, we need to take the impression, then we pour a model, we send it to the lab, lab guide makes the design, they send design approval to the doctor, then we do the production and manual finishing and then a final delivery. Whereas in the digital scan, real-time data is sent to the laboratory, they can just check the scan, they approve the scan and treatment plan is executed in a 3D production manner. So very much almost half the steps are eliminated. Soft tissue and color rendering, where we can easily detect the soft tissue data into the intraoral scan files. Like we can detect the bleeding, where is the bleeding area, where is the enamel is ending, and if there is a recession is over there, we can the different color of the tooth in a cementum surfaces. Whereas in the stone model, we just are working on the monocolor models. So right now we will go with the intraoral scanners, applications of intraoral scanner. So I will share some of the cases which we have done with the intraoral scanner very successfully. First thing is the FMR case. So patient doctor provided us the preoperative photograph as well as the preoperative scan data. So this is a preoperative scan data of the patients. Then this is a preoperative planning. We provided the digital mock-up to the doctor. Once the planning was approved, same thing with the lower. So ExoCAD software was used to provide the planning and 3D files to the doctor. Once doctor approved the file, we processed with the digital mock-up. Then the chairside temporaries were provided. Smile drive was given to the patient. Once the patient was okay, we executed the same planning in the zirconia crowns. We did not take any manual bite or any manual impression. We just took the pre-operative scan and the post-operative scan. So we overlapped both the files and both the scan data and both the planning data into the CAD/CAM software. And same way we executed into the final designing, and the final zirconia were fitted. Minimal adjustment were expected, and then patient was uh, ready to go just in the 4 or 5 appointments. So that is how FMR case can be completed flawlessly. Similar case of FMR, whereas in this condition we did not have any pre-operative data. Doctor directly provided us with the prepared teeth surfaces. So we had a final scan of the patient. Then we did a manual bite registration. Then we did that was the done with the measurement of the VD at rest, and we did occlusion. So we came to know how much VD can be raised. We raised the VD into the CAD/CAM software in a virtual articulator. Then we did a trial run in the patient's mouth. Once it was okay, then we produced the final zirconia, and this is the final outcome of the zirconia in the patient's mouth. So patient was happy, and it was a completed case within just 15 to 20 days. No manual impression, no manual bite. Similar case of full mouth rehabilitation. Pre-operative data was provided. Then a pre-operative wax mockup was digital mockup was done. Then we did the reverse method preparation into patient's mouth. Then we got the final scan of the patient. So we did the rather than doing the digital mockup, we did the pattern trial. That's a kind of same prototype trial we can do, PMMA trial. So patient can have an idea about the aesthetic, what he is going to get, fullness about the prosthesis. We can check the phonetics of the patient as well. So once it is approved by the doctor, we can do the required modification, and same way we can move to the final prosthesis in the zirconia. So that's the preparation, planning, and a prototype trial. That's the end result in the zirconia. All those are layered zirconia. So we did the manual mounting, but we prepared a 3D bite from the patient's prototype trial and mounted it onto the articulator, and then we did the layering of the zirconia. So that's a beautiful outcome of the patient's zirconia final prosthesis. So that's a case of going stone model to the digital data. So that's the impression provided by the doctor. Multiple errors are there in the poured stone model. Multiple bubbles are there, marginal discrepancies are there, but still doctor insisted to provide us with the prototype trial or pattern trial, we can say. So we sent a prototype trial, and we can see there is a multiple discrepancy in the margin over there. So these all are the discrepancies generated by the pouring mistake by the plaster department, or the trying out of the alternate impression, or shrinkage expansion of the double base impression, we can say. So with the intraoral scanner, we can avoid all these errors and minimize the chances of errors in the final processes. So in particular case, we decided to go with the intraoral scan later on. So that's the intraoral scan data, and directly a metal tile was fitted snugly, perfectly up to the margin in a final processes. So that's the beauty of the intraoral scanner, where we can directly jump to the framework trial or BIS trial in a given vertical dimension and particular bite if, provided by the operator. A similar case of a veneer, where anterior 323 were prepared by the doctor. Initial planning was done on the Exocad software. Once the doctor approved the planning, we did the final press veneer lithium disilicate, and here is a beautiful outcome in the patient's mouth. So these are the all kind of application where intraoral scanners can be used in a prosthetic part. In a right now we will see some of the other parts of the dentistry where we can use the scanner also. digital smile designing. So this is a completely model-less protocol. Pre-operative scan of the patient was provided, then a pre-operative photographs provided, and initial treatment plan was discussed with the doctor. That patient is not happy with the spacing in both the quadrant besides the peg lateral incisor. So we decided to preserve the centrals, and we decided to put extra later and to go with the planning of 234, 234 in both the side. So additional planning was required by the doctor, and we also insisted we should try another planning as well. So the second planning was we included the central incisor and decided to go with the 323. So we did the planning on the patient's photograph. Then we did a planning in the Exocad software. We did the digital mock-up. Patient was smile drive was given to the patient. Patient was okay with this 6 teeth. So we decided to go with the same treatment protocol in the final. So final preparation was provided. We made 6 anterior zirconia crowns, and on the right side here is our final outcome of the 6 zirconia crowns. So we can do all kind of required necessity to match the aesthetic requirement of the patient. We try to maintain the midline as well as the golden proportion ratio. In a perio, we can do surgical guide, or we can say gingioplasty guide. So we did a scan of the this patient, intraoral scan with the MEDIT scanner. Then we got the CBCD of the patient. We matched the soft tissue, hard tissue data into the Exocad software. Then we evaluated how much free gingia is over there and how much gingioplasty can be done. So accordingly, we designed the gingioplasty guide. We 3D printed into transparent resin, fitted, fit, we checked the fit of it into patient's mouth, and the final gingioplasty was executed. And immediately patient was given the temporary crowns. So this is a periodontical application where we can go with the we can go model-less, and we can have a better idea of the soft tissue and the hard tissue combination. For a pedo patient, we can also do the scanning for the space maintainer, habit appliances, bite appliances, palatal expanders. Because right now all the companies are providing the uh, pediatric scanners scanner tip with their basic scanner combo. So we can do the scanning into pediatric patient, as well as we can do scanning in the limited mouth opening patient or OSMF patient. We can do the scanning of distal of 7 with the small tips as well. Orthodontic application. So basically it's a common feature of the orthodontist or the internal scanner, where we can do the 3D simulation of the patient's scan data, and we can do the planning of the aligner. We can show it to the patient. We can send PDF or a screen recorded video to the patient as well. So basically right now standard companies like 3Shape, Medit, Itero, they are providing a free module to do the 3D rendering or 3D simulation of the patient's teeth, and we can do the ortho simulation as well. So that's a added advantage for the premium scanner companies as well. Real time we can check how much tooth movement is required and how much aligners are going to be required for a particular treatment planning. So implant dentistry. Implant dentistry has become much more easy with the intraoral scanner. If a scanner is operated or handled by the good scanner operator, and the designer of the laboratory technician is that much smart, because we see good number of failure cases as well in the intraoral scanner compared to the conventional scanner techniques. Like in the particular case, if we are scanning more than 4 or 6 implants, we are going to get trouble during the final fitting of the process or during the metal trial. But if we do the component selection properly from the company's guideline, we can do a full mouth case of implants easily with the intraoral scanner. Imagine this situation. So basically, we got this impression into the laboratory where only one prosthetic screw was used to take the impression, and there were two transfer coping. So we got a impression in a condition where two lab balloons were attached and one screw was fitted like this. So we asked the doctor what is this condition. Doctor explained that he was not able to fit all three transfer coping parallel together because the condition of the transfer coping was like this in the clinical side. So it is impossible to take this implant position into laboratory with manual impression. But it is possible to do the scanning of the particular case by alternately placing the scan bodies, and we can do the scanning of the particular case. And similarly, we can make the 3D model and we can go ahead with the final prosthetic planning rather than compromising the whole case. So that's the model-free digital workflow. So we got a preoperative models of the patient where all the teeth were present. Planning was to immediate extraction and then to give a patient immediate temporary PMA processes. So we did the virtual extraction onto the model. Then we did a surgical guide planning. So we did the planning of the prosthesis, and accordingly we clubbed the CBCT and did the virtual implant placement. We preserved the video of the patient. So then we did the virtual abutment placement and a PMA, final PMA designing with temporary cylinders pickup holes. So immediately after surgery, doctor can place the temporary cylinders and pick up it with the acrylic and just finishing it off. And patient is ready to go with the final prosthesis, interim prosthesis with the PMA. This is a completely model-free workflow. Case of zygomatic implant. Whereas in these conditions, these multi-unit abutments are in such a angulation that if a doctor is trying to remove the impression tray from the patient's mouth, it is impossible to remove the impression from the patient's mouth without distorting the impression, because all the transfer coping are into the odd detection and in a heavily undercutted areas. So in these conditions, intraoral scanners can easily scan that area, and we can easily do the prosthetic planning, or we can easily make the simple step impressions and the 3D printed jig trial to verify in the patient's mouth. So same case with the prosthetic planning, and we can do the trial on a prototype trial, then only we can go with the final processes. In the case of fibula graft, where it is impossible, it was difficult for doctor to make a custom tray and record impression. So we did intraoral scanning. Then we designed the 4 smart abutments. So all the 4 smart abutments were designed in such a way that the final prosthetic direction is corrected, vertical cantilever is eliminated, and then we did a trial run on the 3D model. Prototype was checked in patient's mouth and the 3D model as well. Then we did the final processes with FP2. That's a combination of the red and white ceramics. Case of mucormycosis, where it was difficult for doctor to even select a tray with impression tray to take an impression. So we decided to go with the intraoral scanner. So we placed the multiple scan bodies and did the scanning with the covering the defect as well. So it was a simple case follow up for the doctor later on, because we just did the prosthetic planning and we provided the removable prosthesis with the ball and socket type. So this is a complete digital workflow for the OSTEM multi-unit scan body, where we go from jig trial to the final process fitting with each and every step digitally. So first the internal scan bodies are placed in patient's mouth, and scan upper and lower scan is carried out. So this is a digital jig verification, where we do the 3D printing of the jig as well. So rather than making a pattern resin jig, it is better to go with the 3D printed jig with the titanium base, which is company provided. So we are not incorporating any manual steps over here. We are just taking the 3D printed jig, which is fabricated from the patient scan data directly, which is fitted into the 3D model. So it is directly fitting in the patient's mouth. Completely passively, we can do the single screw test also. So this is a completely digital jig verification. Then we do a prototype trial to verify is into patient's mouth to check the fullness, visibility, freeway space. Then we can check the videate trace and videate occlusion. Then that's the final metal ceramic process is fabricated into DMLS. So there's a completely a digital workflow where we don't need to do any jig trial or anything manual steps. Then a model-free workflow for a smart abutment, where doctor didn't have any kind of impression components or any components for the prosthesis for the particular implant system. So we decided to go with the scanning of the particular patient with the intraoral scan, with the lab scan body. So we blasted the lab scan body, we send it to the doctor. Doctor did the upper and lower scan with the scan body only. Then we directly designed the smart abutment onto the scan data. We milled the smart abutment into titanium. We sent the abutments to the doctor. So doctor just fitted the abutments into patient mouth, and then doctor took the rescan of the abutment. So till now we haven't fabricated or produced any 3D model yet. So it's a completely a digital model free workflow till now. Then we fitted the abutments into patient mouth. Then we did the scanning of the abutment as well. So we directly designed the zirconias over it, and the final zirconias were delivered. So we just went from zero components to the final prosthesis with the help of only one lab scan body. No investment from the doctor side as well. So we can go in a particular workflow as well. So what are the points doctors should evaluate before sending the intraoral scan to the laboratory? That the margin should be properly scanned. So clear cut margins should be visible. Should not be any bleeding into the margin. If any subdivisional margins are placed, then the cord must be placed and the retraction should be proper before the scanning. Otherwise, there are chances that the proper margin might have not been scanned. Then a proper contact area needs to be scanned. Otherwise, if there are deep contact areas, it is difficult for the scanner to scan the particular contact areas. And then we can get a error into final procedure about the tight contacts or a loose contact or ill-fitting contacts. The proper bite should be evaluated. All the upper and lower teeth should be in a proper intercuspation manner. It should not be open bite like this in a final scan data. Otherwise, software there are chances we get a final procedure with the major high points. Minimal autocorrection of the scan data. All the scanner companies are providing a smart software which can do the data correction into the scan software. But that should be the minimal, because as much as the software is making the correction in your data, you are losing the accuracy of the actual scan data, and you may get a final prosthesis with ill-fitting or some kind of adjustment. So the limitations of the intraoral scanners are they cannot record deep margins or deep contact areas, we can say. Another thing is if a bleeding is there or excess salivation is there, it is always difficult to do the scanning of particular patients. Like we can see on the screen, there are multiple errors in the scan area. So we can uh, take the impression of the particular patient where impression material can displace all these discrepancy or bleeding or soft tissue and record the particular tooth surface properly. So even in this condition, we can better to go with the manual impression technique. So there is always difficulty in scanning inflamed gums, then signing metal surfaces, non-sandblasted implant abutments, and bleeding gingiva. So that's the conclusion that with numerous advantages of the intraoral scanner over the conventional technologies and in collaboration with the CAD/CAM, we can always go with the better dentistry towards the digital side. Thank you. and that's the future. There's the big camera system where we can do the extraoral scanning of the particular implant system. So basically, it is recording the particular it is recording the position of all implants in a single click, where we don't need to do the scanning of particular each and every scan body again and again. So that's the future going to be introduced in India real soon. Thank you so much, sir.
Thank you very much, Dhaval, for an excellent overview of all different types of cases that you showed. And especially of interest was that of the oral and maxillofacial prosthesis that can be very easily. One of the biggest shortcomings over there is taking a successful impression in those cases. And
Right.
that's where intraoral scanners really, really help in solving those problems, customizing solutions, and also providing mock-ups for these kind of cases with a virtual planning.
Right, sir. Thank you so much, sir.
We have one question from one of the participants who says that if two implants are simultaneously placed but converging to each other, how will an iOS help with impression?
Yeah, so in particular condition, we can place a scan body simultaneously. We can do the scan of one scan body, then we can lock it. We can shift the remove the scan body and add it to the another implant, and then we can do the additional scan in the particular region. So we get us both the scan bodies scanned together. And in laboratory, we need to design a process in such a way that we can get the parallelism of the final processes.
Yeah, thank you. I think that answers your question, Rhythm. That we can take one scan body impression, lock it, and then move to the other scan body. So therefore, we avoid the collision between the registration of the datas. And of course, that overlap of the scan abutments is okay, because then that the software will stitch it up together.
Yes, sir.
Yeah. So just a query from my side, Dhaval, in
Yes,
your experience, do you what is the percentage of intraoral scans versus impressions that you get in your laboratory?
So right now we are getting almost 30% cases via intraoral scanner and 70% through conventional impression. But the trend is changing very much on a higher side, because 1 year back it was hardly 5% for the intraoral scanner. So right now we are also providing multiple scanners on a rental basis. So we are also creating awareness for the doctors. If they are not willing to buy a scanner, they can utilize our scanner for their more than 3 unit, 5 unit complicated cases. So we can minimize the errors of the conventional impression or the conventional techniques.
Yeah, I think that's a super move where the lab is providing the scanner for those people who don't want to invest.
Right.
So it would help and fast track a lot of lab workflow.
Yes, sir.
Also, in terms of with all those FMR cases that you saw, do you generally find that clinicians tend to take a manual bite registration, or is it a process digitally done?
Yes, if we have a particular pre-operative in a tooth supported case, if we have a pre-operative data, we prefer to go with the digital mockup. Then we cross verify the VDA trace and VDA occlusion in patient's mouth first. Then we evaluate how much VDA needs to be increased. So in particular condition, we can directly jump to the framework trial. And then we only take a cross-check bite in a silicone or bite registration paste. And in an implant case, we prefer to go with the conventional way, jaw relation and teeth setting trial. Then only we move to the framework design.
Okay. And most of these mock-ups that you do, are they 3D printed or are they milled PMMAs?
No, sir. Basically, we first do the 3D printed mock-ups. Those are tried into patient's mouth. Once it is okay, we do the milled PMMA to patient for wearing a period of around 10 to 15 days minimum. Then only we go with the final process in PFM or zirconia.
Okay, so then a second scan is taken of those prostheses in the mouth to be able to superimpose and replicate them.
Yes, sir.
Yes. Perfect. I think that answers almost all the questions and the important aspects of intraoral scanning.
Right,
Uh,
sir.
we are going to be streaming this on Facebook anyways. So if there are queries that come up, we would request you to be free and available to answer them.
Definitely, sir. No worries. Anytime.
So once again, thank you very much, Dhaval, and see you again soon.
Yeah. Thank you
Maybe
so
at
much, sir.
yes, and hope to see you all at the Digitize conference in Mumbai to be held on the 31st, 1st, and 2nd, 31st March, 1st, and 2nd April.
Right,
Thank
sir.
you very
Definitely.
much and see you soon.
Thank you, sir. Bye-bye.
Bye bye. You
Bye, sir.
stop sharing on Facebook first, Dhaval.
Yes, sir.
Yeah, thank you. So